I'm just here to welcome you. Thank you very much for being a part of this morning. I'm going to have Jim Evers come up and kick it off and give more of the details of what's going on, but thank you very much for being a part of this.
I appreciate that. This is a large turnout, which is an excellent thing. Before we get going, one of the first things I want to do, none of these events happen without some sponsorship, and it's definitely important. David Suddeth is here with Bond Secure. I saw David earlier. We chatted. He's waving in the back. So thank you, David, and Mike Reardon with Greenville Hospital Systems. I saw Mike, who is the immediate past chair of the chamber as well. So thank you for giving us the opportunity to do that. And let's wave everybody up. Let's kind of clap here. Everyone's kind of, there we go. That is no indication of how we feel about you, Representative, that no one clapped when you sat down. So I appreciate that. We do have a couple of more of elected officials in the audience. This is a chamber coalition type event, and when we do that, we'd like to be able to recognize those who go out on that limb, as I say all the time, and knock on doors on Saturday morning to get their message across, and then go down and represent us, either at our city council, county councils, or down at the State House. Representative Dan Hamilton, you've already met. Thank you so much. I saw Senator Mike Fair here, Senator Wunschmuller, and then also a sponsor and also an elected official is David Suddeth, Greenville County Council, and I saw Lillian Brock Fleming as well. Hi, Lillian. Thank you guys very much, and thank you all for your service very much. As Representative Hamilton said, the issue of Medicaid expansion and Affordable Health Care Act is a hot topic for businesses now, and it's obvious by the turnout of this event that it is for everybody. The Upstate Chamber Coalition focuses on important public policy issues just like this, and will continue to bring forums just like this later in the future. Not necessarily to take a side on one way or another. We're not advocating that, but we're educating those of you in the business world that are going to see the impact of what happens, whatever happens. And so these are great kind of things, and want you to understand that that's the purpose of this. We are going to have time for Q&A afterwards. I'll explain that in between our speakers when we do that. I think we'll go ahead and we will go ahead and stay in the same order we were in, unless, do we need to get a flash drive or anything put in? Or we can go with Thornton first. Okay, we'll go ahead. I'm going to introduce, we have two speakers today, Dr. Tony Keck, who's the Director of Department of Health and Human Services for South Carolina, and also Thornton Kirby, who's the President and CEO of the South Carolina Hospital Association. Each is going to speak for a little while, and after that, we've agreed to do some Q&A. I know Dr. Keck needs to be at another meeting, so he's going to leave fairly quickly afterwards, so we'll get all our questions in, and I'll explain Q&A between the two speakers. So right now, I'll go ahead and introduce Thornton first, then after that, I will introduce Dr. Keck. Pardon me for having to put my cheaters on for the President and CEO of the Hospital Association. I apologize, but I want to follow the script here. Thornton Kirby served as President and CEO of the South Carolina Hospital Association since 2005. In that role, he interacts with hospital CEOs, physicians, state and federal legislators, agency heads, business leaders, and educators to represent the state's hospital community. Thornton chairs the boards of both the South Carolina Office of Rural Health and WellVista, which is an organization committed to improving health and wellness for the uninsured. Recently, Thornton was appointed to the Joint Commission Board of Commission Resources, which is a nonprofit affiliate of the Joint Commission, which is an independent, not-for-profit organization that accepts and certifies more than 17,000 healthcare organization programs across the United States. Thornton's a graduate of the University of Virginia and USC Law School, and before joining the Hospital Association, Thornton practiced law for Nexus Pruitt in Columbia. He also served as Vice President for the Regional Medical Center in Sumter and spent 8 years as a Senior Administrator of Clemson University. His diverse experience in healthcare, law, and higher ed give him a unique perspective on the public policies issues facing South Carolina. Thornton, thank you.
Thanks, Jim. It's a pleasure for me to be here this morning and also to share the podium with my friend and colleague, Tony Keck. Tony and I have done this a number of places in the state and will continue to do it, I'm sure. I'd be remiss if I didn't start off by saying that this issue, Medicaid expansion, puts us in a bit of a, the old adage, politics makes strange bedfellows. Normally that suggests political adversaries come together on a particular issue. This is one in which partners that collaborate a lot are on different sides of an issue. The agency, the Medicaid agency, and the hospital community have partnered very closely, have worked well together over the years, and partner on a lot of different issues to drive improved health and more efficiency in the Medicaid program. But you're going to hear from us today two different perspectives on the Medicaid expansion, which derives from the conversation around the Affordable Care Act. I'm going to share with you the hospital's perspective, and then Tony will share with you the agency's perspective, and we will answer any questions we can to help you think through this issue. So whenever I talk about the Medicaid expansion, I try to start back from a big picture perspective. And we know that health care is an issue that is divisive in this country right now politically. It has been the subject of a lot of political controversy in the last few years. And so I'm going to start kind of at the top level of politics and work our way to this issue. We spent 2012 waiting for the election that would tell us who would be the president. Was it going to be Mitt Romney, in which case we would go one direction with the Affordable Care Act, or would we re-elect President Obama and go a different direction? Well, now we know how that election came out. We know that repeal is a long shot because of the fact that the Congress, even if it were to repeal this law, the president would not sign it. Congress doesn't have two-thirds who would be opposed to the law to override the president's veto, and so the law is going to stay in effect at least for the foreseeable future. But that does not mean the debate is over. There's still a lot of conversation about the Affordable Care Act, not only in Congress, but also at the state level. And it has come to the states because of this question of Medicaid and expansion. So let me bring us back to the end of June last year when the Supreme Court made a ruling on the Affordable Care Act. You'll remember that the primary issue was whether the individual mandate was constitutional. And the Supreme Court ruled that indeed it was constitutional, not because of what most lawyers thought, which would be a Commerce Clause argument, but because the Supreme Court concluded that the Congress is not actually requiring anyone to buy insurance. The Congress is going to impose a penalty on people if they don't, which is not unlike, according to the Supreme Court, not unlike giving a tax break for home ownership or for having children or for whatever else the Congress wants to prefer with its tax policy. So the Supreme Court said it's just a tax on behavior one way or the other, and therefore it's constitutional. That was a little bit of a surprise, although most people thought that was a very close issue. The bigger surprise was that the Supreme Court ruled that the Medicaid expansion piece in the law was not constitutional as written. So let me describe what that piece was. The Affordable Care Act attempts to cover nearly all Americans, a lot more Americans, through two strategies. Increase commercially insured patients through the individual mandate and large employer mandates on one hand, that's commercial insurance, and on the other hand, by expanding the Medicaid population across the country for low-income individuals. And the law said states must expand their Medicaid programs. We will give them financial support to do so, but they must expand those programs or risk losing the very substantial federal matching dollars that already come to their states in their existing Medicaid programs. Just as a refresher, remember, Medicare is a national program, federal. It's funded by payroll taxes across the country, and it works the same in all 50 states, essentially. So there's one Medicare program, but in every state, there's a different Medicaid program. And why is that? It's because the Medicaid program is a joint federal and state program that's funded in part by federal dollars and in part by state dollars, and the federal government puts foul lines, if you will, around what the Medicaid program can look like. But each state has flexibility into how it wants to administer its Medicaid program. So there's one Medicare program, there are 51 Medicaid programs, counting the District of Columbia. So the Supreme Court said, if you want to keep the money you're already getting from the federal government the Congress said if you want to keep that money, you've got to expand. The Supreme Court said, nope, that is too coercive. You're putting too onerous condition on the states that choose not to expand. In other words, threatening to take away all the money they're currently getting is too big a penalty. Now, why did this surprise people? It surprised a lot of attorneys because, in general, the federal government, when it gives money to the states, can put whatever conditions it wants on it. For example, all the states have the right to set their own speed limits, but you'll notice it's 70 in virtually every state. Why is that? Not because the federal government can set it, but because the federal government conditions its grant of federal highway funds on having a speed limit no higher than 70. So the states say, well, we'll take that deal. We can set our speed limit anywhere we want, but just so you know, we're going to let it be at 70 because we've chosen to do that. So that's the way the relationship between the feds and the states works. And the feds said, if you want this to keep your big pot of money, you've got to expand. And the Supreme Court said you can't do that, it's too coercive. What did that mean? It means every state now has the choice whether to expand its Medicaid program. That's how we got to this debate. That's why the conversation is coming back to the states, and that's why there's so much dialogue about it in South Carolina and many other states. So that raises a political question. What are states going to do? Well, we look back historically to 1966. You'll remember, if you're a student of history, that Medicaid was enacted in 65. So it came online in 66, and only 6 states jumped on it the first time it was available. 20 states came on later in that year. So at the end of the first year that Medicaid was out there, only half the states had participated. The next year, another group of states came on, and then another batch came on over about a 5, 6, 7-year period. And that included a lot of the southern states, which were not sure they wanted to participate in this federal program. You'll see up there, Arizona did not come on until '82. So historically, it should not be a surprise to us that all states don't want to do the same thing at the same time. That's what we're seeing now. That's what we saw in 1966. Now, why are states reluctant? There are a number of reasons. It's no surprise to anyone in this room that there is a lot of anti-Obama sentiment in this country, and there's a lot of anti-Obamacare sentiment as a result. But there are other reasons as well, and Tony will enumerate some of those much better than I can, but let me suffice it to say that states' rights is a doctrine in politics that's alive and well. The states don't want to be told what to do by the federal government. Many of them resist that. There is an administrative burden. Whenever a state administers a program, there is a cost associated with that. And when you expand a program, there's a cost associated with it. Tony will talk more about that today, but that's a real issue. The two that I think are most difficult to deal with are the fact that 10% is still a big commitment. Now let me expand on that a little bit. According to the federal law, if a state chooses to expand its Medicaid program, the first 3 years, the federal government will put all the money up necessary for that expansion. Eventually, the federal portion will decline to 90%. Well, that sounds like a good deal. If you had a 9-to-1 return, most people would make that investment. The problem is there are investments in which the 10% you have to put up is more than you can do. So, for example, if I offered to give you a home today that's worth $5 million, I'll give it to you as long as you pay 10% of it, but you have to give me cash here before we leave today. Not many of you are holding $500,000 in cash. So that's where the states are. They're saying, it may be a great deal. If I don't have the money, I can't do it. I'm not going to participate. So that's one of the issues that states are having to contend with. Many of the states that have opted to expand have said, well, we're going to develop a strategy for how to come up with that 10%. And so there are a number of different strategies that have been adopted. The other one is a fear that the federal government will not keep its commitment financially. Now, you don't have to be a conspiracy theorist or a government hater to worry about this, because we are struggling with a debt and a deficit reduction crisis in this country. If we're already talking about what to do with Medicare and Medicaid, it is reasonable to say, I'm not sure that 90% is going to be here in 7 years or 8 years. Those are valid concerns. And then the last one that's often called the woodwork effect is the idea that there are people currently eligible for Medicaid who are not enrolled. They have not enrolled. And when you have all this publicity about what's going on, they may come and enroll, which is their right to do. And no one is saying that we wish they would not, but people are acknowledging that it will it will be a new cost in the budget to state governments. Now, the budget for a state government is currently responsible for that, but not paying for it right now. So think of it as a contingent liability. It's on the books if the people come, but they aren't coming. If they do come, then you have to spend the dollars on it, which is a budget impact. So those are the issues that are in play in every state in the country, not just South Carolina, and they tell you why this is not an easy discussion. Now, who isn't participating? You'll see there is a red-blue split in general. A lot of the states that have committed themselves in the blue are primarily Democratic states. A lot of the red states that have said they're not going to do it are primarily Republican states. So you can get the feel that this is coming down on political lines, not surprisingly. This is about who's going to participate, which states will participate in the Medicaid expansion. The next slide is a different question, and that is which states want to run their own health insurance exchanges. This is another part of the federal law, and you see kind of a similar split. You see some of the states that tend to be more blue states saying they want to do it. The red states say they don't want to do it. On this one, they're using red and green. But many states are saying we'd prefer not to run our own health insurance exchange, let the federal government do it. So that's kind of a background. You can see then the nation is divided over this question. This is an interesting conversation starter that is about which states benefit and which states lose under the expansion. This was prepared by the Kaiser Family Foundation and the U.S. Department of Health and Human Services. It asks the question essentially, if every state expanded, how many people would go from uninsured status to insured status, and how much would that reduce the number of uninsured in the state? So the winning states would be the ones that have the highest number of people reduced from the uninsured category. So they would have a greater drop in the number of uninsured than the states that win the least. So look at the far right-hand column at the bottom. Massachusetts, which has already done its health reform, would stand to gain the least. They don't have as many uninsured states or people in their state as others. And Kentucky on the top left would be the one that benefits the most. But what I want to use this slide for is to suggest to you this is a partisan political issue. It's got a lot of ideology embedded in it. It's not just rationality or financial analysis. And let me suggest why you can glean that from this slide. The left states, on the left, the 10 states that benefit the most, 9 of the 10 are red states. On the right, the 10 states that would benefit the least, 8 of the 10 are blue states. So in one manner of speaking, the blue states are fighting for the right to transfer wealth to the red states, and the red states don't want to have anything to do with it. That is not the way it works with federal highway funds, for example. The arguments are the other direction. So I think this is useful to understand that there is a lot of ideology in politics in this debate. It's not just a financial question. How much is the expansion, how much would it cost South Carolina? Tony, I believe we're using the agency's numbers. If these aren't correct, you please correct them. But in the first 3 years, it would not cost us anything. That's what some people have called the teaser rate. The federal government is saying, come on in, we'll pay 100%. Then you have to start putting your own state money in. And then the federal government will put in money in the far right-hand column. And over that period of time, you see a state total contribution of about $440 million and a federal contribution of a little over $11 billion. Now, that's what sets up this conversation about the 10%. States would love to have the $11 billion, but they're not comfortable committing themselves to the $442 million because most states are struggling with their budgets and their economy. So this is the scenario that causes so much of a split of opinion. State impact reports, because of the Affordable Care Act, the way the law is structured, there is a desire to reduce cost shifting. Cost shifting is delivering care to people who can't pay, and then hospitals turn around and charging someone who can pay, normally commercially insured patients. In an effort to minimize or mitigate cost shifting, this law seeks to cover the uninsured and pay for it in large part by reducing the payments to hospitals for Medicare and Medicaid. So We're not going to pay hospitals as much for Medicare and Medicaid. In exchange, though, we will make sure everyone has a form of insurance so the hospital doesn't have to engage in the cost shifting it has been engaged in. And so that is the $2 billion that will come to South Carolina in the form of cuts. Now, our state lawmakers did not make that decision, but it is nevertheless a real cost to South Carolina, to the hospital community. There will also be cuts in the Medicaid disproportionate share funding that comes to hospitals to pay for uncompensated patients. But as yet, we are not sure how and when they will come. We believe that it will be somewhere around maybe closer to 600,000. I'm sorry, 600 million than 700 million. We believe that will come over this 7-year period. We just don't know when it's going to come because of the fact that the CMS federal agency has not given us the ruling or the regulations yet. So you see, this lays out what hospitals, through their lenses, they see a lot of cuts coming to hospitals and the possibility of bringing a lot of federal money to the state to backfill and to pay for that. And the question is this a wise course of action? We did an economic impact study. We asked the University of South Carolina to do an economic impact study. The hospitals did, and the university prepared that. And what they concluded was that if it's true that $11.2 billion will come to the state, that by 2020 the annual economic impact will total about $3.33 billion in annual output. They estimated 44,000 jobs. That number, not surprisingly, some have questioned, but it's what the university came up with, and approximately $1.5 billion in labor income. Now that will produce, anytime you put more money in the state's economy, it produces more spending and therefore more tax revenue, and they estimate another $105 million in general fund revenue. If that were all true, $105 million in general fund revenue, it would offset the state's costs for the matching dollars for this first 7-year period. It does not offset the costs beyond 2020, and there are questions about how that will work. What will be the matching rate? The law is unclear whether the matching rate is going to stay at 90-10 or go back to where the state matching rate currently is, but there will be some monies available in tax revenues generated to offset the state's portion. Now, what have hospitals been doing? This is the slide we've used with hospital folks to say you can talk to your legislators. That is obviously what all groups do when they have an issue they want to discuss with in terms of state policy. We've also talked to business leaders, just like we are today, and we've talked to physicians in our state who are also affected by this. This is the best way I know to sum this up for the simplicity's sake. There is a burden of uncompensated or indigent care in our state, in every state. That indigent care is free to the recipient, but it is not without cost to the provider. That cost must be borne somewhere, and we essentially have two strategies for bearing that cost. One is through Medicaid. The other 49 states are offering to help us bear the lion's share of that cost. The question we have to ask is, would we rather they give us that support through Medicaid, or would we rather they not? And if we don't let the other 49 states help pay for the indigent care in our state, then we have to pay for it somewhere within our borders. Whether that's government or whether that is business paying the cost of commercial insurance, it's very hard to put the finger on it, but the fact remains, we can either let the other 49 states help us pay for this. They're offering to pay 100% for 3 years and 90% thereafter, or we can say, no, we're going to cover this ourselves. To me, that is the simple way to think about this question. And it begs the question, which one makes our state more competitive? But I do think that we need, one of the things Tony and I have talked about a number of times is the fact that this is not the only issue. It's an important issue and a political issue. It's not the only issue our state needs to grapple with in terms of competitiveness. We've got to do a better job of increasing the health of our population, improving our healthcare delivery system, and lowering the cost of care. When we look at some national and international numbers, South Carolina is not faring well in our health outcomes. This is a diagram of something that's been referred to a great deal in the last few years as the triple aim. If you want to have a recipe for improving healthcare and healthcare costs, you've got to work on population health, you've got to work on the care delivery system and make it as good as it possibly can be, and you have to work on lowering the per capita cost of healthcare. If we want to lower costs, we've got to focus on the delivery system, and we've got to get ourselves healthier as a population. Let me give you a couple of statistics. A recent report came out last month, comparing about 17 different developed nations in their healthcare outcomes. Tony speaks of this a lot and sensitized me to it, so I went and looked for it. This is the Institute of Medicine, published last month, less than a month ago, compared to health status. When you talk about health status, America is last, dead last among all these nations. So the first chart is deaths from all causes. America's at the bottom. Second one is maternal conditions related to pregnancy. We are at the bottom by a long shot. Road traffic accidents, we're at the bottom, and violence, we're again at the bottom by a long shot. When you look worldwide, if you can see the title of this piece at the bottom, it's called The U.S. in International Perspective, Shorter Lives and Poorer Health. Regardless of economic status, regardless of age, we don't live as long and we are not as good a health as any of these other nations. So that points out a problem with our state. We are not optimizing our health. Now, in the least healthy developed nation, we are almost last in South Carolina. We're 46th out of 50. Last year we were 45, so we're not going in the right direction. So why the low health status? Here are the ranking. Here are the top 10 factors on which we perform poorly, and you can see our rank against all other states. And then the weighting is whether they give it a high, medium, or low rank. You can see even though smoking is number 10, that is a high predictor of poor health status, so it's weighted highly. There are a lot of things to do on here. One of the reasons hospitals feel as though we should entertain this Medicaid expansion is because of number 6, the lack of health insurance is one of the predictors or the factors driving low health status or poor health outcomes in our state. Many of these are generational. You can't fix them overnight. This is one we could address in a short period of time. Now, I said that we have to make 3 things happen: better health care, and lower cost of care. Health, we are one of the least healthy states in one of the least healthy nations. We've got to have a plan that's data-driven to move us forward. I know Tony is committed to that. Catherine Templeton at DHEC is committed to that, and so are we. Better health care, we have been recognized as a state, our hospitals have, and many other partners, for leading the nation in improving quality and safety of care. We have demonstrated that we can do the right thing and we can get out ahead of the national curve. But there's a lot of work left to be done. We've got to focus on making health care as high value as it possibly can be. When we spend $1 on health care, it's got to be high value health care. I do want to tell you some good news. CMS, the Center for Medicare and Medicaid Services, recently ranked all 212 regions in the country that have multiple hospitals and tried to figure out where the quality was best. They were giving penalties for poor performance and bonuses for high performance. They ranked the top 10 markets in the country for high value health care, and 3 of them are in South Carolina. And Greenville is number 2 in the country. When it comes to value, Greenville is the 2nd highest value market in the country, according to CMS, on these measures of quality. Florence and Charleston are also in the top 10. That is surprising to many people. It's not surprising to the hospitals that have been working on this and to partners like Tony and Health Science of South Carolina and Blue Cross Blue Shield. We've spent a lot of time working on it. Lower cost, fundamental complaint about our cost in this country is, our healthcare, is it costs too much. We have 2 drivers for that. One is the fact that we are not healthy, and the other is our healthcare system needs to deliver higher value. Those are the 2 strategies we need to be pursuing as a state. We've got to be, it's not enough just to reduce the cost of care and make healthcare delivery more efficient. If we keep getting less healthy, we're going to spend more and more money on health care, so we've got to do both at the same time. So that's really the strategy. You can see that Medicaid expansion in the view of hospitals is important for two reasons. Number one, the Affordable Care Act, whether we like it or not, opted to reallocate money away from Medicare and Medicaid from hospitals so that we can cover more people and have a more equitable distribution of money to reduce cost shifting. If you cut the payments to hospitals but you don't cover more people, you don't accomplish the goal of reducing cost shifting, you exacerbate it. That's number one. And number two, we've got to address our health status as a state. And one of the many drivers of health status is the fact we don't have access to health insurance. We're 45th in the country, and this is a strategy whereby the other 49 states would help us accomplish that. So that's the overview. I know that Tony will give you his perspective, and you'll be enlightened by that as well, and then he and I can answer questions at the end. Tony? Or Jim, do you want to introduce Tony?
Every day I always try to learn something new and take home and tell my kids something I learned today. And number two in, as Thornton said, number two in healthcare value, Greenville, United States. I'd like to see a show of hands of anybody that would move to Fort Wayne, Indiana. Yeah, so I'm really happy where we are on that. That's always great news. As sometimes happens when you look at a large crowd like this, I scan out and see a couple of people I didn't recognize that I wanted to recognize. Cindy Crick, representing Congressman Trey Gowdy, is here. Thank you very much. And I also saw Danielle Gibbs, who represents our newest senator, Senator Tim Scott. Thank you guys for being here. When Representative Hamilton talked about the Upstate Legislative Caucus that he's a part of and Senator Fair's a part of, I just didn't want any confusion before I introduce Tony. I didn't want any confusion that the Upstate Chamber Coalition is a coalition of chambers of commerce made up from multiple. And Mark, I wish I knew the number. Elizabeth, 12. There we go. 12 chambers in the Upstate. And I know just looking out, and I'm not going to ask a show of hands. I see Greenville Chamber here, Greer Chamber here, Anderson Chamber here, and Spartanburg Chamber well represented here as well. And I know there's others. Chambers of commerce that can get together on business issues like this, it really is. I will tell you, it's an anomaly. You don't see this. I've been all over the country. You don't see this kind of a working together attitude, and I really appreciate the Chamber's lead on those kind of things, and Mark and Elizabeth for your work. Thank you very much for doing that. What we're going to do now, Elizabeth, did you get the, you could tell I was filling time while she put the flash drive in. Did we get the, not true for Danielle and Cindy, I wasn't filling time for you. Did we get the flash drive put in for Tony? Okay, so we're good to go. Very much. I'm going to introduce the second speaker, and then we'll have Q&A, and during that time, Elizabeth, if you could pass out some cards now. Because we have such a big crowd, we got a feeling there's going to be multiple questions. So Elizabeth's going to pass out some cards for some questions, and we will pick them up after Tony's done. If you know a speaker that you want to, and don't worry about it if you haven't thought anything yet and you want to, write a name, who you want it to go, or to either one. If you don't indicate anyone's name, we'll just present it to both of them. But because this is such a high-profile issue, we get so many multiple questions. We feel those that, let's say that there are 10 questions of the same question from this organization, we would like to address that first as opposed to just maybe one or two individual questions, only for the sake of time. So please understand, we're not trying to keep any questions from coming up. We're just trying to get those that are the most prevalent up front. So that's how we're going to do it. Tony Keck, or Anthony, but he goes by Tony Keck, is the director of the South Carolina Department of Health and Human Services for Governor Nikki Haley. He holds a bachelor degree in industrial engineering and a master's in public health from the University of Michigan, and is completing his doctoral thesis right now on health systems and management at Tulane University, focusing on physician workplace issue. Tony has 23 years of experience in healthcare management and consultation and policy. Prior to his appointment in South Carolina, he served the administration of the governor of Louisiana as a health and social services policy advisor to the governor and as chief of staff and deputy secretary for Louisiana Department of Health and Hospitals. Tony, thank you.
Well, thanks. I appreciate the invitation, and as Thornton said, we really have been doing a traveling road show for, I guess, about the past 6 months, and the running joke is that you only have to attend the last 5 minutes of our presentations, because the first 30 minutes of each presentation is pretty much the same. We're talking about a lot of very similar things in terms of our analysis of what's happening in American healthcare, what's happening in South Carolina, and what we should do about it. We get to the last 5 minutes, and then we have to talk about our disagreement on the Medicaid expansion. So I'm going to start out that 5 minutes at the beginning and talk a little bit about the numbers and make a few, I hesitate to say corrections to Thornton's numbers, but I'll say suggestions maybe. But really quickly, for a lot of you who don't know the structure of the Medicaid program, essentially Medicaid in this state serves over 1 million people a year now. It's the largest single payer in the state. The program is a program that you become eligible 2 ways. One, categorical eligibility. So for instance, you're age, blind, or disabled, or you're a pregnant woman. And then you also have to meet certain income limits. And this is a representation of those major categories, and the blue and the green bars are what we cover right now. And the red is where you see that we're going to have to, if we expanded, start to cover folks. And basically what's happened is that the federal government has said, let's do away essentially with categorical eligibility and put everybody at 138% of poverty. So below 138% of poverty, you don't have to be categorically eligible. Everybody now is eligible by virtue of your income. And what that primarily does is bring a lot of adults into the system. We don't cover, most states don't cover childless adults right now, but we also don't cover some parents and so on. So what that does is the entire Affordable Care Act expansion would bring in about 500,000 people into our system. Right now we cover just over 1 million. We bring another 500,000 in. Actually about 1/3 of those are the people that Thornton mentioned are currently eligible but unenrolled. So they're eligible under our current system, but because of changes going forward, they'll enroll. So it's really 344,000 new people who would come into the system. This gives you a little idea of the Medicaid program. As soon as I stop talking about Medicaid, I'm mainly going to talk about health care and health care costs in the United States. I think one of the things we get distracted by a little bit, and I hate to use the word distraction, but the fact is when it comes down to it, we're talking about a decision to expand or not expand, which is going to affect the lives of about 200,000 people in South Carolina out of about 4.5 million, and that's an important conversation to have, and we're going to talk about those folks. But the reality of what's happening with healthcare cost and healthcare outcomes, as Thornton was pointing out, how bad our outcomes are. The other 4.3 million people, they are in a system that is not working, that is out of control, and we'll talk a little bit about that. This gives you an idea about our current Medicaid program and how it's grown over the years. And you can see that until 2011, it was growing significantly, and then that's when I came on board with Governor Haley, and at mid-year we had a $250 million state general fund Medicaid deficit, and so we had to implement a series of changes to get us back on track. But you can see that between 2007 and 2014, the program has grown 38% in terms of total expenditures. If we hadn't taken those actions, the program would be over $1 billion bigger right now, and that would have been a 64% growth. So you can see I've annualized both of those growth rates. This is not a sustainable growth rate in a country whose gross domestic product is only increasing a couple % per year. Now this is basically how we get there. I won't spend too much time, but if you want to know the Medicaid budget, you take the number of people that we pay for each month and you multiply it by the cost of every person per month, and that's how you get the budget. it obviously gets much more complicated than that, trying to predict those numbers, because we don't really control either one of those numbers. We have to predict, and we have to put in systems that try to control them, but the reality is there's a lot of variability in them, and that is a large part of our reason that we don't think we should jump into expansion, is because there's a huge amount of projection risk involved with doing this. Now, really quickly, we can talk about this later in more detail, but Thornton's numbers tend to use the most optimistic approximation of what the Medicaid expansion would cost us. This is a complicated slide, but the headline is the most important, that the current Medicaid program alone, just the current Medicaid program, no expansion, is going to need an additional $2.4 billion of state general fund between now and 2020. Those are pretty solid numbers, because we can predict those trends pretty well. Expanding to get to that additional, if we brought on that additional 344,000 new people, would cost us anywhere between $600 million and $1.9 billion. And the reason there's such a huge range there is, one, because you don't know how many people are actually going to show up, and so we have risk there in measuring that. Connecticut expanded early under the Affordable Care Act. 2 years ago, they projected that 50,000 people were going to come on board. Actually, 87,000 people came on board, and so last December, they declared a $190 million deficit in the program. So that's one big projection risk. The second is prices. When supply gets outstripped by demand, when we bring hundreds of thousands of new people into the system, we're not creating any more doctors. Actually, we might have fewer doctors going forward than we have today. And so we believe that prices are going to go up. That price inflation is nowhere in the federal estimates. They said, oh, it's too confusing to estimate what will happen to prices. But if you take Economics 101 and demand outstrips supply, you know what's going to happen to prices. So those are the numbers that we use from our actuaries. They actually are tracking more and more closely with some of the national level estimates done by folks like Kaiser and so on. Now, I said I was going to talk about the healthcare system in general, because again, we really need to understand what's happening in American healthcare right now, and we need to work not just as a Medicaid program, but we need to work all together to get this under control, because it is seriously damaging not only our nation's health, but our nation's economic competitiveness. This is the triple aim that Thornton mentioned, and I use this to just throw up the Affordable Care Act and the performance of the healthcare system right now up against the triple aim and say, are we achieving what we want to achieve, and can the Affordable Care Act as it's structured do much about it? And my answer is no. And so we'll take a look at reducing per capita costs of health care, improving health of populations. I won't talk much about the third, but as Thornton mentioned, actually South Carolina and a lot of the work that the Hospital Association has done is really leading the country in probably this third one in terms of improving outcomes inside the organization, inside health organizations. So this is just a quick map to show you what's happening to healthcare cost growth in the United States. It started out tripling every decade in the United States, total expenditures. Now it's slowed down to about doubling every decade. There's been a lot of news about how the growth in the past 3 years has been the lowest growth in history, 3.9%. The only problem with that is that real GDP actually grew negative 3.1% in that 2009 year, and then only 2.4, 1.8%. And so healthcare continues to grow faster than GDP, and the problem with that is that it takes more of every single dollar that we generate in this country. And that means it takes a larger portion of every paycheck, it takes a larger portion of every payroll, and it takes a larger portion of every state budget. And it's the Institute of Medicine who has been doing a lot of reports on costs lately, because they say, look, if you believe in the social determinants model, which Thornton pointed out near the end of his presentation, most of those things on that list of 10 were actually social determinants that don't have anything to do with health services. 80 to 90% of healthcare is income, education, or of health is income, education, personal choices, social supports, and 10 to 20% is actual health services, yet we are continuing to crowd out spending in those areas by investing in health services that are not delivering high value. And this whole conversation about the sequester right now, and everybody talks about how stupid it is, the reason they're having to make all those cuts, lots of them in what we would consider investments in the United States and social determinants, is because nobody will touch the entitlement programs. Nobody will touch Medicaid, nobody will touch Medicare, nobody will touch Social Security. And so what they're doing to preserve health services, which are not producing as much as we need in this country in terms of health, they're cutting everything else. And that's what's happening in the states. We're having to cut higher education. We're not able to invest in roads. We got a $29 billion backlog in our road maintenance to get things from the port up to the BMW plants and back. So this is very well acknowledged a significant problem in the United States. The problem is that the Affordable Care Act doesn't reduce this. And so 2020 is 19.2% of GDP goes to health care. That's an increase. So in a health reform bill that is supposed to be tackling what really is one of the biggest problems we face, which is out of control health care costs, the Affordable Care Act actually is more expensive in 2020 than the current system. It takes more out of every dollar. So it's not living up to its billing in that. This is a problem for us as a purchaser, and many of you are purchasers. We purchase on behalf of the state. Many of you purchase on behalf of your employees. But we're spending all this money, and the Institute of Medicine and other folks like McKinsey estimate that about a third of it is waste. $765 billion in 2009 alone, just to put some perspective on that. That's enough to pay the insurance premiums for 150 million people in the United States. Just the waste alone, okay? And yet we're talking about a plan which puts more and more money into the health system without asking for very much in return. Now I'm going to skip over these. These basically just talk about how much money the federal government is borrowing to pay for health care. It borrows about $1 in every $2. Now, we probably wouldn't be all worked up about this spending if we had the best health outcomes in the world. I'm not going to go over these slides too much because Thornton really has already done that very well. But we are falling further and further behind in terms of life expectancy. Actually, some income groups are going backwards. White women with less than a high school education actually lost 5 years of their life expectancy in the past 2 decades. This is a map of obesity rates in the United States between 1990 and 2010. I stole this from Thornton. And you can see that we start out with no states above 14% obese in 1990. But in 2010, the map is all red, which is greater than 30% obese. Now, this is during a time when we're spending all that money on health care, all that money on health services. It grew 4 times during this period. And we just get fatter and fatter, which means we're getting less healthy and less healthy. This is another map of South Carolina. This is actually a map of everybody who has, every adult who has Medicaid in South Carolina. So take insurance out of the picture, and basically this map is a map of chronic disease, and if you're in the blue area, you are much, much healthier than the average, and if you're in a red area, you're much, much less healthier than the average. All these people have insurance. They're all covered by Medicaid, and yet they have incredibly disparate health outcomes, and that's because most of health and well-being doesn't have anything to do with insurance and health services. It has to do with that list of 10 things that Thornton talked about in terms of education, in terms of personal choices, and so on. Now, I usually don't get this far in the presentation, but since Thornton gave a lot of my presentation, I'm a little bit further. I get to talk about what I think needs to happen. So the healthcare business model must change. I stole this slide from Greenville Hospital System when I sat in on their board retreat to get an idea into what they were thinking and what they were planning for. Basically, the healthcare model has to change. What's happening is that over time, our current healthcare model's value is decreasing. And lots of folks, when they think about big industries, they think, well, nothing will ever change. We can't change it. I hear lots of defeatism in the news and so on about we got to take the money because there's nothing else we can do. We can't change the system on our own. Well, big systems do change. Borders is out of business because Amazon and Kindle is selling books electronically now. The United States Postal Service has a $16 billion deficit this year because more and more people are doing business through email and FedEx. Ma Bell, now they actually reorganized themselves, but copper wire went out of business, major change, but they reorganized themselves into something different, wireless. This is what happens to healthcare. We cannot pretend that these gigantic industries and these gigantic corporations that have been around for 100 years or more always stay the same and nothing's ever going to change and we can't do anything about it. We can do something about it, and so we have to do something about it. So in terms of what I think, and this is taken, hopefully most people think from the accepted research, we've got to change our business model in a few fundamental ways. First, we've got to move away from fee-for-service that drives healthcare providers to concentrate on simply stealing market share from each other and drives them to do more and more because that's how they get paid. They get paid for everything they do, and that's everything they do to sick people. They don't get paid to keep people healthy. The second thing is we need some serious transparency in pricing and outcomes for consumers and payers of healthcare to make better decisions and to increase competition in the market. We've got to remove barriers to competition at all levels. We've got a lot of anti-competitive behavior in healthcare that we would never allow in any other industry. And so doctors try to make sure that nurses don't do certain things, and certain doctors try to make sure other doctors don't do certain things, and hospitals try to make sure that they can get as much market share as possible by pushing other people out of business. There is a lot of anti-competitive behavior in the market, and we've got to deal with that. Like I said, we wouldn't let it happen in any other industry. We've got to focus on total cost, which requires that we spend a lot more time thinking about clinical integration. Our system is so fragmented. We've got hospitals, we've got all sorts of different types of doctors, we've got durable medical equipment, we've got home health, we've got nursing homes. All of them try to maximize their returns and try to maximize their outcomes independently. And what we know from around the country and what we know from a lot of work that's being done in South Carolina right now, a lot of it up here, is that integration makes better sense. We can't continue to chop people up into little bits and try to solve their problems by chopping them up into little bits. We've got to view them as the whole person. And when we do that, we're actually able to reduce cost. And that can, in turn, increase profitability. If it costs less to care for somebody because we have to do less things for them, most payers that I know, including me, are more than willing to give some of that extra money that's saved back to the providers. And so that's one of the things that we're trying to do. And then finally, consumers must share more of the cost. The reality is we are just too over-insured in this country. We are over-insured in the United States, and we are too separated from the cost of our care. There's a great book called Catastrophic Care, How American Healthcare Killed My Father, that just came out about 2 months ago by a guy who's a CEO of the Game Show Network, of all things. But he had the time and he had the inclination after his father died in the hospital with $1 million bill to take a deep look into the U.S. healthcare system. And he talks a lot about this insurance problem, and there's lots of research that talks about us being overinsured, but it's a nice way for, I think, business people to engage in the question. So, if we're overinsured, expanding the Medicaid model, which is an insurance-based model, is not necessarily the smartest way to do this. Now, you know, I stand up here and talk all over the state. Thornton talks all over the state, and I quote the Institute of Medicine and all sorts of folks. If you don't listen to me or you don't trust the Institute of Medicine, go pick up this Time magazine article, which is on the shelves now. This is a special report that just came out from Time magazine. The entire issue is devoted to healthcare. It's the only time they've ever done it. Essentially, the whole issue is one article about healthcare cost and taking a deep dive in a way that I don't think the media has ever done before, taking a look at how the U.S. healthcare system is I'm trying to think of a more scientific term, but out of control. and not producing the results we want. They make some really important observations in this article. The most important is, while we're spending all this time debating about who pays for health care, we're missing the real point of why are costs so high. And it goes in detail in a very engaging way, taking a look at individuals' bills and so on, about what is actually happening with not only hospital finances, but the pharmaceutical industry and so on. This is an industry that spends twice as much as the oil and gas and defense industries combined on lobbying in Washington. So this sort of Pollyannish view that many people have about the Norman Rockwell physician sitting in his office and taking care of people for chickens no longer applies in the United States. Healthcare is the single most powerful industry in the United States, and we, as purchasers, as employers, people who are paying the bills, we have to start to take an attitude towards this industry that recognizes this is a gigantic negotiation, and every dollar that the healthcare industry takes is a dollar from employers, is a dollar from individuals, and is a dollar from government. So I really encourage you to go take a look at that article. Now, so the reality of what's happening in South Carolina, if we do not expand, what we many times don't hear from the hospitals is it's not just about all the cuts they're receiving. There's also massive increases they're receiving on the subsidy side. And so half of the Affordable Care Act is actually putting massive tax subsidies into the health insurance exchanges. And the health insurance exchanges are going to be operational, presumably, throughout the United States, whether it's a state exchange or a federal exchange. The federal government has committed to having those running in all 25 states that are not running their own exchange. And so when that happens, several 100,000 new people are going to have access to affordable insurance through significant subsidies. Everybody above 100% of poverty all the way up to 400% of poverty is going to get significant subsidies from the federal government to buy insurance. And so we go in South Carolina from a snapshot of the uninsured at about 731,000 people down to a snapshot of about 210,000 people that if we don't expand, that's a change of 500,000 people. Even if we don't expand, those 500,000 people will now have access to affordable care. Now, part of the conversation with the hospitals is, well, how many will avail themselves of it? But we have to really ask ourselves a question as a state. If the federal government is going to give somebody a 90% subsidy to buy insurance, and then they're going to also decrease their co-pays and decrease their deductibles by 50%, if they decide not to take the federal government up on that offer and walk into a hospital and say, well, I don't have any insurance, I paid my $95 penalty, please give me free care, what's the responsibility of the hospital and what's the responsibility of the state? So we're undergoing a massive shift right now where we have to think differently about who's paying the bill. But even without expansion, you can see the major changes that are happening right now. This is a major turmoil in the market, which I understand is probably causing hospitals a lot of concern. And this is their biggest concern right here, is that these are different payer boxes. And so you've got Medicare, and they pay a certain rate, and you've got Medicaid, and we pay a certain rate. You've got the private market, and then you've got the uninsured. And even the uninsured pay hospitals in this state. We pay 57 cents on the dollar, so it's not that they're getting nothing for all the uninsured. We spend $461 million this year on payments to the hospitals for the uninsured. So we are a payer through Medicaid for the uninsured. What's happening in the hospital's eyes, and this is important, is that the Affordable Care Act is changing these boxes all around. And so one, it's adding a new box called this exchange, because that's actually a different market than the private market. But all of these now have different payments associated with them. And so Medicare is going to pay less in the future than it does today. Medicaid, right now, we're holding everything equal. We actually are building into our budget increases. The private market is a mixed bag, but most people think that people are going to shift from the private market into Medicaid or into the exchange, and that's going to pay less. But on the uninsured side, look at all those positives. Everything that happens to the uninsured is a positive for the hospitals. And this is not what's discussed. This is never discussed in all those cuts that you saw, this massive increase in the number of people who are going to have payment increases. is not discussed. So we're working with the Hospital Association to model this right now, but we're having a hard time understanding how hospitals are going to lose in this deal, especially if they become more efficient. So I'm going to take 5 more minutes, and I think I have to end up. So understanding what we think needs to be done with the healthcare system in the United States and in South Carolina, what do we need to do? We are laser focused on improving value, which means lowering costs and improving outcomes, or some mix thereof. Now, what does that allow us to do? One, the money that we free up when we do that allows the bigger state government, it's not all just Medicaid, but I got a whole bunch of cabinet officers and other agencies that need money. It allows us to take some of that freed up money and invest it in education, infrastructure, and economic growth, which, if you believe in social determinants model, that's where you really need to be putting your money. Second, it lets us shift healthcare spending to more productive health and healthcare services. So there is good spending and there is bad spending right now. And the more money that we can pull out of the bad spending, the more that we can put into the good spending, such as primary care. That money also that we free up allows us to invest in vulnerable populations that aren't being covered. And one of the, I think the big fallacies of this debate is that insurance is the only way to get people health services. So when people do need health services, and I'm not saying that they don't, most of us will need health services at some point, but when they do, insurance is not necessarily the only way to get it to them. In a lot of countries that we talk about, oh, all these countries have universal health care, why can't we be more like them? Well, a lot of them don't do it through an insurance model. A lot of them do it through systems similar to federally qualified health centers, or they do it with systems similar to the current DISH program that we have. So you don't have to insure people to get them services. And that's what a lot of our alternative is that was presented in the House a couple weeks ago, is that it actually is focused more on looking to where our serious needs are in health in this state. And you saw the differences between the red and the blue areas. We know there were hot spots where people need our help. It lets us focus our dollars much more accountably on the populations in need. So just a couple quick things about that plan. For the first time ever, it says, look, hospitals, we're going to give you money. We're going to give you additional money to get into the system, and it's a significant amount. But to do that, for the first time, you're going to have to do 2 big things. You're going to have to coordinate with federally qualified health centers to manage the uninsured that are showing up in your emergency rooms. Because right now, there's only a few hospitals, a few progressive hospitals, that really bother to do anything about the people that show up in their emergency room. There's very few places that actually work closely with the clinics that serve the uninsured, that work closely with primary care doctors to say, hey, this person has been showing up in the emergency room every week for the past 6 months. Maybe we should reach out and figure why. Now, there's some innovative things going on up here with community paramedics, where actually paramedics go out into people's homes who are frequent flyers in the ER instead of waiting for them to show up. But for the first time, we require hospitals to do that to get additional funds. The second thing is we require they're going to have to participate in a serious price transparency program. And so we're putting lots and lots of money into hospitals, but as the Time magazine article I hope you all read will point out, we have no idea how much that care really costs. We have no idea. And so the legislature said, look, if we're going to be spending this many billions of dollars, we've got to have a much better idea of what the prices are and what we're getting for our money. Now, on the other side, we're giving money to the clinics that serve the uninsured. So we're making a $10 million investment in those clinics this year. And we're going to require the same type of transparency for them, but we're not just going to hand them the money. We're going to require that they integrate with these hospitals and work on these uninsured, high utilizers of ER services that have chronic disease. That's actually getting great reviews nationally and locally. And so, because people understand this is where the problem is. This is where a lot of the excess costs in our system is. And so where the hospitals worry about all the uninsured that they need to take care of, this goes directly to this problem without making a major expansion of Medicaid, which, as I pointed out earlier, is much too expensive. So I think I'll leave it there so Thornton and I have time to answer questions. I've certainly got a lot of backup. I can talk about the jobs report, which we think there's a lot of problems with, and so on, but we'll just take questions from there. Thank you.
We're going to figure out how to do this. I will say, I'll probably have both of you come up here and take time. We won't go at blows. I know you guys are good friends. And so we will do that here, and I'll just be out in the audience, and we'll speak loud enough that you can hear the question, and the audience can hear the questions as well. While we're getting set up, I want to address a question that's come from a professional question answerer, or question giver, to both of you while we're getting all set up to do that, and whoever wants to go first is fine. And that is, obviously, this is a complex and politically charged issue. In this political climate of today's culture, as is the case often during tough economic times, is there hope of a consensus in how the state of South Carolina will handle the Medicaid expansion?
It might be better to poll some of the legislative representatives in the office. I mean, look, no matter, so the map that was shown from Thornton is a map that changes on a weekly basis. And it's a map of what governor's stated intentions have been. But that, as we know, is not the final say in almost every state. The legislature has to weigh in. And so it's not so clear that when a governor says X, Y, Z is going to happen, that's actually going to happen in the state, because legislatures have a mind of their own. On the one slide where Thornton said who's going to benefit the most from Medicaid, and we had all the, I guess, the red states over here, and we had all the blue states over here. I noticed in that list of blue states were New York, California, Illinois, and Massachusetts. All four of those states right now are implementing massive cuts to Medicaid because they can't afford their current programs. California just made a huge tax increase. They've cut they cut reimbursements by 10% last year. Illinois had to make a $2 billion cut in Medicaid because they hadn't paid providers for 8 months, and they're falling about $500 million short on their goals. So although I think there's a lot of maps out there about who's taking this and who's not, I think as Thornton said, it's going to be an ongoing debate. And so I don't think there's been consensus for many years in the United States about health. I think the consensus that we are going to have is that we can't afford what we're doing anymore. There's going to be debate about how's the best way to reduce costs and improve outcomes, which I think is a great debate that we're having. But I don't think the debate for much longer is going to be how do we make these programs bigger, because the states that are saying that they're going to expand are cutting back their programs significantly right now and are going into debt because of them. And so I think that within a year or two, once we see how this all settles out, that we're going to have the consensus that we can't afford this anymore, but then we'll continue to sort of argue how do we get there.
I would echo what Tony said and add a couple of points, maybe 3 points. Number one, the question was about political compromise. There was an obvious opportunity for states to compromise around the degree to which they expanded their programs. Maybe we don't go to 138, maybe we go to 100. The administration made a ruling that the law does not allow that. It's either you fully expand to 138 or you don't. And that took away a lot of fertile area, I think, that might have been ground for compromise. The difficulty with this issue is it's pretty difficult to compromise on a binary issue, yes or no, expand or don't expand. Well, that's one of the reasons that I think Tony and I both have tried to make sure we're not myopic. This is not the only issue facing our state. There are a lot of issues, and he made a point that the House Republican leaders and the agency and the governor have tried to offer a plan that's broader, has more pieces to it. Now there are those, including hospitals whom I represent, who say this can't replace the losses that are coming from the Affordable Care Act, and that's true, but the state can't make that necessarily on its own without expanding Medicaid. So I think that what we have to continue to do, and I think you're seeing Tony and I are both trying to do, and that is focus the question or the conversation back on the bigger issue in this state, the bigger problem, which is we are increasingly unhealthy, and that is going to kill us with respect to our health care costs. We do need to figure out what we're going to do with these several 100,000 people, but 4.3 million people in general are costing us more and more every year because we're less healthy. So, you know, I don't know about the political compromise either. I just think it's difficult on a binary issue like that. So, questions?
Thank
Jim?
you. With the new law, can you estimate the breakdown between the direct care of patient cost and administrative cost?
Well, I guess in Medicaid that, you know, we have a fairly low administrative cost in Medicaid. It's somewhere between 3 and 4%. We expect.
Tony, would you mind stepping behind the podium so we can hear you?
We have
Thank you.
about a 3 or 4% cost of care in Medicaid. Actually, if you include our managed care companies, it probably goes up to maybe 6 or 7%. So there's going to be significant new administrative burdens on the tune of maybe $100 million a year over the next decade, but that's paid for 50-50 by the federal government. So I don't think it's creating a huge new amount of administrative burden, really. When I hear people talking about what their opposition is to the Affordable Care Act, administration is sort of one thing you add to the list, but it's not an overly burdensome part of it. Now, administration in our healthcare system in general, I think if you take a look at the Institute of Medicine's 6 domains of excess cost, administrative duplication and waste is number 2 on the list at about $190 billion a year. And a lot of that is because payers like Medicaid and Blue Cross and so on make it very expensive for hospitals to actually administer the way that they deliver care, and I think that's something that we absolutely have to work on.
Okay. Thank you. We're still sorting through the questions with the multiple questions to make sure we hit the big ones first. If demand for Medicaid Medicare increases, I have a 9-year-old daughter, and I can read her handwriting better than this. I don't know who wrote this question. If demand for medical care increases with Medicaid participants, will or can doctors refuse to see Medicaid patients? And as a follow-up, what will happen to those patients if they can't be seen?
Yeah, doctors do right now, and there's no law that says you have to accept Medicaid. And again, you know, I point to some folks who recently flip-flopped on their position, Florida and New Jersey, in terms of the Affordable Care Act. New Jersey just said they were going to expand. New Jersey, according to Health Affairs, has the lowest rate of acceptance of new patients in Medicaid by physicians in any state in the country. Only 40% of physicians in New Jersey will accept new Medicaid patients. California and Florida and New York and a lot of these expansion states in Illinois are actually in the lowest tier of acceptance of new Medicaid patients. And the reason is because when you get really generous with how many people you're going to put into the program and how many services you're going to get them, the only place to manage the budget is by cutting reimbursements. And so this Health Affairs article shows almost a perfect correlation between the percentage of your payment related to Medicare that you make in a state for Medicaid versus how many doctors accept Medicaid patients. And so if you pay less, fewer doctors accept patients, and if you pay more, more doctors accept. In South Carolina, we actually are one of the highest payers in the nation. We pay about 80 to 83 cents on the dollar, and we get about an 84% acceptance rate. California, Illinois, New Jersey, they're paying down around 50 cents on the dollar, so they have much less acceptance rates. So Yeah, more and more doctors are going to turn away Medicaid patients, and that's what's happened in Massachusetts. Massachusetts expanded from about 93% of their folks being insured to about 99%. They have more doctors than any state in the country almost per capita. They're a very wealthy state, but what happened when they expanded is their emergency rooms and their safety net clinics got even more busy. They got more full with Medicaid patients, because what happened is private doctors who saw the new private patients come in said, oh, wait a minute, I can continue to see my 20% Medicaid patients, or maybe I can see 10% Medicaid patients and then bring in these new folks. And so there was a huge displacement of Medicaid patients in Massachusetts, and we would expect the same thing to happen here in South Carolina. So I'm worried about keeping my tenuous network of doctors together right now, because I'm generally the lowest payer compared to everybody else. And so now when all these new private patients come into the market because of the exchanges, the smart doctor is going to say, well, I'm going to see fewer Medicaid patients, and I'm going to see more private patients, and I'll make more money. And then that leaves Medicaid holding the bag, and that leaves poor people out in the cold, as usually happens in these types of things.
I would just add that the law does not require in this country physicians or hospitals to see Medicare or Medicaid patients. If you're a physician, you opt in and you decide I'm going to participate in Medicare or Medicaid. You're not obligated to take unlimited numbers, and that's what Tony's talking about. For hospitals, it's a little different. Again, if you opt in, you can opt in or opt out, but if you opt in, you have to see patients in that payer group. So Tony is trying very hard, and his predecessors have tried very hard to keep paying physicians and hospitals a rate that will keep them in the game, so they don't back out, as the questioner was asking. And so you can begin to see the complexity of this. As Tony said, it's tenuous. The provider community doesn't want him to cut rates either, because that makes it very difficult for hospitals to get their physicians to participate. So this is a balancing, and I suspect as long as Tony is protecting the rates as he has done that over time, we're not going to see wholesale physician departure from Medicaid, but obviously that's a worry.
Okay. I want to add to that. It's a reason why both the Medical Association and the Nursing Home Association are not supporting Medicaid expansion. The Medical Association's official position is, though we support access to care to all individuals, we do not believe that the Medicaid expansion is sustainable. And the Nursing Home Association came out with a similar position, where they observed that by increasing Medicaid on this side of the ledger for all the childless adults and so on, it puts a lot of economic pressure on the side of the business that deals with individuals living with disabilities and the elderly, because there is nothing new in the Affordable Care Act for all those folks, and we spend a couple $2 billion a year on those folks. And if we have to start spending more money over here on these folks to get our state match, then that means that, barring raising taxes, we're going to have to go look other places in the budget, and there's a good chance we'll go look in nursing homes and home and community-based services and services for folks living with disabilities who aren't really included in this bill.
Let me just add one last thing. Tony's right, and when physicians look at Medicaid, the more Medicaid patients there are in the healthcare economy, the greater percentage of their patient population may be Medicaid. That is not in their best interest financially, because it's not as strong a payer as a commercial insurance plan. So they are making a rational decision there, and I guess the same would be true for nursing homes. The reason hospitals are behaving differently is because they don't have the legal right to limit the number of people they take care of who don't pay them anything. And so that's why they behave differently, because they see, if I've got to take care of an unlimited number of uninsured patients, I'm very interested in seeing them get insurance, whatever form of insurance it might be. So again, complex. I think if you dig in, you can see rational behavior among all these different groups.
Okay, this question is directed to Tony. Why do you consider, or at least present, healthcare reform and Medicaid expansion as being mutually exclusive? Why not push for both and ensure those most at risk?
I didn't write that one.
Yeah, I think I know who did. I have a meeting later on this afternoon with him. But Yeah, so I mean that's a good question, and so I guess I'll answer from two perspectives. One, as a perspective of somebody who's run big organizations before, I just think that the health system has limited bandwidth to do both at the same time. Businesses tend to focus on making their bottom line either by growing revenue or by focusing on cost and efficiency, and it's very difficult to make major changes related to both at the same time. And so if you're flooding the market with patients and new money, it's hard to get organizations focused on efficiency and so on because so much money's flowing in the door. And I think, so that's my background just in operations. People will argue that. I think the other reason is because fundamentally, if you take what I had said about the core problems, I think in the U.S. health system, it's just a bad investment. Insurance is not the solution for every person in the United States. It's just not. And there's very few health models around the world that rely solely on insurance to get everybody the health care that they need. And so I just think and lots of other people think the same thing, is that healthcare has taken this huge swing into the health services arena and the insurance arena, when we really need to be focusing on issues like these, which are much more public health oriented. Cindy Scope, one of the editors at the state newspaper in Columbia, wrote an article this weekend saying she can't believe that Republicans are all of a sudden the defenders of public health, because this is a sort of a sea change for them. But the reality is as we've spent a lot of time with leadership working on these issues, they recognize that public health is what's needed in this state, working on those social determinants of care, more than continuing to put more and more money into the insurance and the health services side. So it's not necessarily that we can't do both at the same time. I'm rejecting the notion that necessarily everybody has to go into an insurance-based model.
This is a rather lengty question, but I think one that has been echoed at least on 3 cards that I've seen, maybe 4. Thornton said that ACA is constitutional to provide a penalty if you don't buy insurance, i.e. a tax on behavior. He also said the strategy is to improve health. Tony said the problem is not lack of insurance, but lack of education and poor personal choices. Therefore, how can we change legislation to incentivize healthy behaviors or tax unhealthy behaviors?
Well, I'll jump in because I know Tony has things to add. This is a place where I think we have a lot of opportunity in our state. One of the things that we're already seeing pick up in this state right now is workplace wellness programs, starting to say, okay, I'm an employer, I'm willing to cover your health care premiums or a certain portion of it, but I'm not willing to cover that same percentage regardless of the way you treat your body. The better you take care of yourself, the more I'm willing to pay. The less care you give to your body, the less I'm willing to pay. So, so a combination then of workplace wellness, helping people eat better, diet, nutrition, exercise, combined with premium differentials is one. And I've not spoken with any members of the state health plan or legislative leaders or any others, not committing them. But when I was a state employee at Clemson, the penalty, the premium differential for a smoker was $25 a month. Now, I don't smoke, but I thought to myself, if that were fried food, I would not quit eating fried food for $25 a month. I'd just pay the amount. If they told me half my premium was going to be on me if I continued that bad behavior, I'd think differently about it. So we've dabbled in premium differentials, but we really haven't gotten tough with them yet. And the fact of the matter is, smoking and obesity are 2 of the really worst drivers for the health outcomes in this country. So, so that would be one area. Let me let Tony talk about value-based insurance design, because I think that's another tremendous opportunity we have as a state.
Just real quick, I think you should allow people to ask questions. These questions sound really one-sided. Most of them involve socialism and fascism. I think you should.
Okay, we've got time to answer this question, and this is the last question. So I apologize for that, but this is the last question. Unfortunately, Tony's got to go, or you would be able to corner him before he left, but he's got another meeting.
And I've got a couple minutes afterwards. We can talk and answer. Yeah, I mean, the hospitals are actually are helping lead the way, I think, in working with their own employees in terms of this, and adding incentives and disincentives to not smoke, to eat better, to exercise, and so on. Unfortunately, the federal government, for some reason, doesn't want to give poor people the same, or doesn't want to give a program that serves poor people the same type of tools that the private sector has to actually help them manage their own health. And they're very rigid in their approach to incentives and disincentives and cost sharing and so on. We actually are starting some work with a group called the Value-Based Insurance Design Institute that works out of Michigan and Harvard to help design a set of incentives and disincentives for folks in Medicaid, recognizing that it's a different population that doesn't have as much money to play with as other populations, but still puts a lot more responsibility on the individual. They actually have some relationships in Washington that we think we can help sell the administration on these ideas. It's not dissimilar to what social services and the governor proposed and Catherine Templeton at DHEC a week or two ago related to the food stamp program, that again, if employers have the ability to put penalties, incentives on folks to get them to eat healthier and exercise more to lose weight so their health care costs are lower, why can't we do that in the food stamp program? Somehow, although the administration does lots of nice things in the White House vegetable garden talking about how we should all be healthier and so on, they don't want to make any changes to some of these sacrosanct programs like food stamps, and so we're going to push on them very hard.
Gentlemen, thank you so much for your time. Appreciate it. Unfortunately, with some subjects like this, there just isn't enough time for everything, but we really appreciate you spending time giving us some insights. You're probably going to want to take that flash drive with you when you go.
Thanks for the invitation.
Absolutely. And I want to also thank members, our elected officials that are here. Thank you very much for your time, and for Mark and Elizabeth, who put all this together. A chamber coalition, as we stated earlier, it really does help to speak in a unified voice to our elected officials. Again, we're not here setting policy or even talking about policy. Today was all about education, and hopefully you receive some of that. Thank you for your time, and I'm sure you'll hear more emails down the road. Thank you once again to our sponsors, Bon Secours St. Francis and Greenville Hospital Systems.